in the School of Medicine at the University of Wollongong.
Thank you. And I'd like to start off by thanking the wonderful Di and Liza for inviting me here today. And I wish I would have seen Robin's middle slide with all the definitions first up on yesterday morning, because that makes things look clearer to me. So just the first disclaimer, I'm not a linguist. English isn't even my first language. But I do understand that how we talk to somebody is very important. I'm a clinician. I'm a newborn intensive care specialist. So my patients aren't even verbal. They're vocal, but not verbal. But I do understand the inclusion of the others around, whether they're parents, whether they're extended family or siblings. And I'm not a trained educator, yet I find myself in medical education for a long time. You know, as a clinician, you kind of slide into that, probably very badly initially, but I'm learning as I'm going along. But I find myself now responsible for education. And I guess as a clinician and through my own experience, I think communication is Jen, you talked yesterday about a life and death skill. I don't think that would go down well, but it is an essential skill. We need to get away with language from calling it a soft skill. So when I talk about communication, then what I mean is talking to patients. So I'm going to give you a little bit of an oversight of how education is governed across the world, what we teach in education, but I come to you really with more questions and hope I can get answers from you. So whilst we've had healers for tens of thousands of years, and even textbooks, I guess, written, and information and knowledge about the body and about herbs and treatment and looking at the whole person really being handed down from generation to generation, the first, at least in the developed world, medical school that we know of, which is now closed, was in Italy. And we've still have the University of Bologna's medical school in the States, 1765. University of Pennsylvania opened the medical school, and here in Australia, it's the University of Sydney. But as I said, medical education has gone through an apprenticeship model and handing down information and knowledge verbally, and watching and seeing, to building it on science, having lectures, readings, and an apprenticeship model. In the United States, the Johns Hopkins School of Medicine used the German model to teach medical students or doctors of the future. It was an educational model that built on traditional knowledge, required some research or lab learning, but also bedside learning. And with it, associated with it, was postgrad education in hospitals for interns and residents. 1910, Flexner came along and had a look at all the American medical schools and found that they differed greatly in their quality and in their outcomes. And he produced a report that made lots of recommendations, but also building on the Johns Hopkins model, developed standards for graduating students that were built on medical sciences and clinical training. So since then, we've had different types of accrediting bodies across the world. So in the USA, we've got the Liaison Committee on Medical Education that tells medical schools what the expected outcomes are for graduates. In the UK, it's the General Medical Council. In Australia and New Zealand, it's the Australian Medical Council. I think important in this context is that the Institute of Medicine report in 2001 on health professions and training found that there was a problem. There really was no good training in providing high quality healthcare to patients. And recommendations were made around communication, and some of those around open-ended inquiry and reflective listening and empathy. So let's have a look what happens around the world and what do these accrediting bodies for medical schools actually recommend that medical schools do or teach or expect their graduates to be able to do. So if we go to the States, the LCME has 12 standards, and there's a standard that's called curricular content. And here the faculty needs to ensure that the curriculum includes specific instructions on communication skills with patients, families, physicians, and non-physicians, and you need to prepare for residency communication skills. Doesn't really tell us a lot, right? It's pretty basic, I thought. Okay, let's go to Europe. Let's go to the GMC, the General Medical Council standards. of which there are 10 with 5 themes. And there it is recommended that the learners need to learn how to be open and honest with patients when things go wrong. Communicate with tact, sensitivity, and empathy to give the students the opportunity to support and follow patients. Again, fairly basic, right? And to have skills and procedures and read these, introduce themselves. I mean, these are common things that my mother taught me, you know, introduce yourself, check the identity, confirm the procedure as required, explain the procedure, gain consent, and we are good. But going further, this is about communication effectively and openly and honestly to carry out an effective consultation with patient, collaborative with the patient, support and facilitate, and so on, so on, so on. So these are very high level words, and it tells us what. It doesn't tell how we teach it, how it's being assessed, where's the standard, it goes on. So let's go to Australia. What does the Australian Medical Council tell us? Now, for those of you who don't know, not just in Australia, but in different intervals across the world, definitely in the UK and in the US, but in Australia, the Australian Medical Council sets the standards, and Australian medical schools have to report every year against those, okay? And sometimes, you know, you get a report back, so God, you're wonderful, that's great. Tell us again next year how's it going, whether you change anything. Sometimes they tell us we're not so great, and we have to report back in detail on what we're doing to improve. So it's actually a very serious, very convoluted, very stressful process that is absolutely critical, just like accreditation in hospitals that everybody hates, but they're so important for patient safety, aren't they? So the AMC has domains, 4 of them, and in clinical practice, the graduate is meant to demonstrate the ability to communicate clearly, sensitively, and effectively, be culturally competent, talk about ethical issues, and in the standards that we report against, one of them, the curriculum says that the curriculum has some foundations of communication. Again, not really well spoken, and I'm kind of missed the multiculturalism about that. So the AMC is proposing to change those standards, and there's a little bit more there. Now we're talking about the whole person care. Again, it's about sensitive and effective communication with patients and their families, but to also elicit their needs, concerns, and preferences. So all of a sudden, there's now a demonstration required about how we actually put the person or the patient into the center. Adapt communication is new, and I think much appreciated by everybody who read these. There's a little bit more around culture, and it is about recognizing needs and requirements of patients. So we're on the way there. But again, for me, as somebody who's trying to say, well, how do we do this? How do we assess that? How do we teach students? And how do we know that they are at a certain standard where we can let them loose onto people who are unwell and hope and pray that we've set the foundation for their lifelong learning? I'm not sure that I find that very helpful. So then a little bit building on what Connor told us, I had last week the great honor to trawl through all the AMC reports of all the medical schools and try to work out, what do we teach it? How do we teach it? And as Connor said, I think so every medical school has communication somewhere in their curriculum. We'll do it a little bit differently, but there are a lot of commonalities. Students in pretty much every medical school are exposed to volunteer patients or simulated patients or even real patients very early on, from year 1 on. We teach them skills and behaviors. We talk about person-centered principles. We have patient involvement in terms of feedback, assessment. We do this face-to-face, role play, and so on. We've heard about this. So there are lots of ways that we're trying to get the graduating students who are going to be our doctors of the future to really be able to talk to a patient and to listen to them and to make them part of the communication, actually hand over authority to them. The Cochrane review from Connor, again, gave us some indication on what works and what doesn't work, but it is not the solution. And just like somebody asked you before, my question is, what about the long-term effect? I think one of the questions was, how do you learn from bad, what about those bad examples that you see? I think they're wonderful learning opportunities. I didn't have any communication in my medical school teaching, and I think I watched lots of bad communication going on. And I thought, I'm not going to do that. I'm not saying I'm good, but I use those as learning opportunities. So what about then this lifelong learning? And I'm not going to go into detail, but again, post-grad training, so after medical school training, is also governed by accrediting bodies, at least in the developing world. I didn't look worldwide, but in the UK, in the US, and here in Australia, that's the case. There is one a framework that I'd like to point out, because I think it is the most detailed and it's maybe the most helpful framework, which is the Canadian Medical Education Directives for Specialists, which was developed by 12 Canadian health organizations. And that defines the necessary competencies for all areas in medical practice to provide a foundation for medical education in Canada. And as you can see here on the slide, we look at the medical expert not anymore just by knowledge and skills, you know, knows 35 interleukins and can stick sharp things into little people, but it is about being a professional, whatever that is. It's about being a scholar, a health advocate, and particularly a collaborator and a communicator. And if you go to the CanMed's website, you find that a communicator has something to do with relationships, with information, with perspectives of patients, developing plans together, and document and share that, not just with colleagues, but also with the people one talks to. And there are pretty good educational tools on the website as well. So think of all of these, to me, it's probably the most helpful, but is it being used everywhere, and to what extent it's being used, I'm not quite clear. So then I asked myself, so if I didn't learn communication, and we now have a lot of research and, you know, it's been published for the last 30 years, do we think communication in healthcare, so talking to people, is actually getting better? I looked for 2 days, I couldn't find anything. I can find lots of papers on doing an intervention and measuring something, doing this and finding that. But in general, if I went out to patients at Canberra Hospital, a GP practice, health centre, anywhere, so are we better? Are we better than my parents or my grandparents' generation was? It's very, very difficult. However, there are lots of good things happening, aren't there? We teach it now. Patients, people participate in research, not enough, you know, there are limitations, but it's there, it's happening. Health literacy, we've got handouts coming out of our ears, right? We try to do them in most languages. There's so much out there on social media, and we do a bit of training. So I'm kind of hoping it's getting better. But as I've learned from Carol Harden, who's from the Institute for Healthcare Improvement, hope is not a plan. In medicine, never hope for anything, you make a plan. And she's right, you know, I'm hopeful it is getting better, but I can't prove it. So when I say, okay, what do patients want? And we've talked about that a lot, and I struggle with that, because depending whom you ask, where you ask, when you ask, how you ask, you get a different answer. But I think it's about, and I think Jen talked about that a lot, it's about really listening and meeting the emotional needs. And the emotional needs differ according to age and culture and language and whatever not. It's about trust. Now, trust needs to be bi-directional. Patients want to trust, I'm sorry to call them patients, but I'll just do it at the moment. Trust us. But you know what? I need to develop trust in you as well. And I've got so much to say about your talk yesterday, but you know, if you came to me, I need to trust you that you know what you're talking about, and that you do what you say you're doing, whatever not. So it works both ways. And it is really difficult for students, you know, who are still developing their professionalism or professional identity to understand that. Role modeling, as I said, is fabulous. Good role modeling, I probably wouldn't recognize, but bloody hell, everybody recognizes bad role models, right? So that is actually a teaching tool as well. So we have a dilemma. The health professionals' focus is in explaining the illness to a person and what that means and what they're meant to be doing about that. The patient's focus is to be understood and to get their perspectives across, and their need for honesty and transparency, but also that partnership. So how do we get those two together? Well, through patient-centered communication, which is really around eliciting that perspective, and to understanding what people want, and why they're different to the next patient, and to understand a shared, to get to that shared understanding. But it is very difficult because there are so many constraints, right? Around time and opportunity and language and culture and whatever not. So it's not that easy. Does it actually make an iota of a difference? We all think, yes, communication in healthcare makes it all better for the patients. Well, the evidence isn't that clear. In some areas, of course, patients are happier, more satisfied. Some health outcomes are better, but others, you know, patient recall. Do you remember what the doctor said? Do you understand the recommendations and do you do that? You know, if you talk to an elderly lady about heart failure where she has to weigh herself every day, unless you explain why that is, they're not going to do that because that's, you know, embarrassing and complicated and really keeps you from doing what you're doing in the morning. But it's so important. And again, to think about, and that's where you are, the linguists and the speech specialists, you know, uncomplicated, specific language, use some repetition, like we do in teaching, no jargon, and check that understanding. The one really, really practical tip I learned yesterday here was this teach back, reversed, flipped. So the patient actually checks whether they're teaching. To me, as a clinician, has worked. So these are just my very uneducated, I guess, thoughts about what I think we teach, but what we might want to focus on or should be learned or should be emphasized a bit more. So yes, history taking, but the whole person in context. Information, diagnosis and treatment, but you know, is that really relevant for the person in front of you? Do they understand what you're going on about? The partnership, the recall, enabling self-management, trust, very important, the connection and the patient autonomy. I know we do it, we want to, we're aiming to do it, but our differences and how we teach that or how we understand that students learn it, how it is accredited or checked varies. So there are so many gaps around health literacy and communication skills, set role modeling, time and so on. And that's why I'm coming to you, because I really think that linguists can help us. Yeah. Health literacy, we talked about that a lot, but I was quite surprised that, you know, it's a bit more than undergraduate because there's digital literacy and there's tool literacy and media literacy and critical literacy and whatever not. It's not even in understanding the language, and I'm an educated person. How is somebody going to understand what's out there when they come with a different schooling background or a different language background or have mental health impairment? But I think linguists can help us as educators for that narration in medicine and to focus on the interaction and check that understanding. I think they can give us tips and tricks like we heard yesterday to adapt to culture and age and mental state and so on. And I loved all the pediatric talks this morning because that's another book that I think we forget too often. To help us align what the clinician needs to do and what the patient needs us to do. And maybe think about something called translanguaging, very difficult to explain, which is really what I do, is how do I use real language in a language that's not my language. You already talked a lot about research, but you know, make it practical for us and for us to understand how we can teach or how we can get across that trust goes hand in hand with communication, and to develop some tools and maybe with some ideas for us on faculty development that includes simulated patients as well. So they don't just pass every student, but actually sometimes could be a little bit critical. So lots of questions, no answers, but I hope I have given you a bit of insight into the problems that we struggle with. And I really believe that the education, and it's not just, I just talked about medical schools, but think nursing, students, allied health students, we need to build this up. So eventually the avalanche of better clinicians that have those essential skills will wash out the dinosaurs that don't think communication is important or is a skill. Thank you.